Good evening. It's a pleasure to welcome you to today's ESTS webinar, and it's a great honor to have Professor Lorenz Keulemans from Leuven as a speaker today. He's working at the Catholic University in Leuven and has a strong focus on lung transplantation, both from the clinical as well as from basic research and translational research side. He's one of the few persons, I think, combining lung transplantation and intestinal transplantation, actually also as an additional interest. And in September this year, he's going to follow Dirk van Remdonk, who is known to all of us as well as head of the Leuven lung transplant program. And Belgium is having one of the largest DCD rates worldwide in the field of lung transplantation. So it's a great pleasure and honor to welcome you to this talk, and we're really looking forward to what you're going to tell us about it.
Thank you very much, Professor Eigner. Dear Clemens, dear colleagues, dear friends, it's indeed my pleasure to be here this evening and talk to you about a very exciting topic in the field right now, which is DCD lung transplantation, because so many things have changed over the last years that I think as a thoracic community, it is really important to assess all these changes with care and see which direction we as a thoracic community would like to go. It's okay for me to share my screen now, Clemens?
Yes, that's perfectly fine.
Okay, you can see my screen, Clemens?
Yeah, it's working perfect.
Okay. So in regard to this presentation, I have some disclosures which are unrelated to the field of DCD lung transplantation. So in general, it is interesting to see how the DCD programs has grown worldwide over the last 2 decades, with currently the highest rate per million persons, mostly seen in Spain, the Netherlands, Belgium, but also the UK, and over the last years, apart from Canada, also the US in North America. This is data from 2022, and these are DCDs donations in general, not specifically for the lung. If we, based on this graph of the Global Observatory on donation and transplantation, if we look at this graph of 2022, we see that in that year, 722 lung transplants were performed worldwide from DCD donation. And if you then look, then you can see that the highest percentage, the highest rate of DCD lung transplantation is indeed to be found in Canada, Netherlands, Belgium, and Spain. And not so much in the US, where DCD lung transplantation approximately accounts for only 5% of all organ donation procedures. So I think that there's still much room for improvement, and it is an interesting area because with the DCD heart being procured, there might be even an increased interest for DCD donation, and the lung could benefit from that. Here you see, for example, at our own center last year in 2023, almost 75 lung transplants were performed, and that year our DCD program accounted for 40% of all lung transplantation. So I can say that over the last 10-15 years we have a growing experience with DCD, mostly DCD3, but also DCD5. In Leuven we have never performed an uncontrolled DCD2 until now. What is interesting to see is this graph from UNOS, transplanted last year by Choi et al., where you can see how the DCD lung transplantation evolved after implementation of the DCD heart program. And in red, you can see the absolute numbers of DCD heart transplants performed in the US from 2019 onwards. And there you can see that almost in 2021, more than 200 DCD heart transplants have been performed. On the other hand, you can also see that the trend of DCD lung transplant is going down relatively from 6 to 5% in that same year. And I will come back to this graph because it is important to understand that the utilization of DCD lung transplant should not suffer from the implementation of DCD heart transplant. We have to work alongside and not prefer one organ over the other. So this is the outline of my presentation. We first start with a general concept of DCD lung. We will go over the definitions, the classic technique. I will discuss with you the outcome regarding DCD3, DCD5, and DCD2, what is known in literature, and then share with you how to assess donor lung quality from these organs. Next, we will discuss abdominal NRP and the rapid recovery of lungs and heart and what the impact is of abdominal NRP on the lung transplant outcome. We will, of course, discuss thoracoabdominal NRP, and then I will share the conclusions of DCD in lung transplantation. As a first slide, of course, I give you an overview of the Maastricht classification of DCD donation. You have two main categories, which are the uncontrolled DCD, where the most interestingly one is the DCD2, where you have donation after unsuccessful resuscitation. We have a lot of experience in Spain. I come back to that later. And then the controlled DCD, where the classic controlled DCD is the DCD3, where your potential donor awaits cardiac arrest. And then, but that's in controlled circumstances. And then you have a classic DBD that becomes DCD4 during donation because of an unexpected cardiac arrest. And then there is the modified Maastricht classification with the integration of a DCD5, which is also a controlled setting. And that's the donation with after medically assisted circulatory death or euthanasia, with two subcategories, which is 5A out of OR euthanasia, or 5B in the OR. I think there's room for even now with more experience from the Netherlands and Canada for 5C, where you can have euthanasia at home and then being transported to the hospital. What is important as a community when we discuss DCD, it is important to have a clear definition and consensus on timings and definitions of timings. Everything starts with T0, which is a withdrawal of life-sustaining therapy in DCD2. Depending on the country and the region, this can be performed in the OR or perhaps in ICU. And then something happens because these organs, they will not be ventilated so much anymore, and you will see that there's an increase of relative warm ischemic time until the moment, and that's an important moment, where the systolic blood pressure drops below 50 millimeters of mercury. And I advise every center to really take that moment into account and also write it down in your database. Because after the systolic blood pressure drops below 50, what happens then is that the absolute warm ischemic time or the functional warm ischemic time sets in until the moment of cardiac arrest. Followed by cardiac arrest, there is a differential timing of no touch, which means that no one touches the organ, and that can vary per country from a few minutes up to 20 minutes in Italy. In that period, we await auto-resuscitation. And if that not happens within that certain period of no touch, then 3 independent physicians are present to declare the patient dead, and then at that moment the patient becomes a donor. However, the warm ischemic time has already set in. We start with the incision. The patient is the donor at that moment is reintubated. Ventilation is started to protect the lungs, and then within a few minutes the pulmonary trunk can be incised and pulmonary flush can start, and from that moment the cold ischemic time kicks in. So regarding the technique of a DCD3, I think it's important to realize that in such a setting, it's important to have 3 independent teams. You have one team taking care of the patient. From the moment that donation is considered, there is a team also with the anesthesiologist involved and the transplant coordinator that take care of the optimal strategies to assess and protect the potential organs for transplantation. And then you have the team taking care of the recipients. Here you see how we do it in Leuven. So the potential donor, the DCD potential donor, is transferred to the OR. It's installed on the operating table and is already draped, and all the instruments, the perfusion solutions, everything is set ready. For example, you can see here on the back side of the thoracic surgeon who is standing there, you see the sternal saw lying there and the 2 baskets ready for splitting the legs. What happens then is that the surgical team steps out, and we leave the comfort therapy of the potential donor to the discretion of the anesthesiologist. And there will then, of course, also be present the independent physicians who will declare the patient dead. We await outside. From the moment that cardiac arrest is started, then we go in, and then we have a few minutes. And for now, as a thoracic surgeon, we were always master and commander in the chest of a DCD. We didn't have to look at anyone, only communicate very well with the abdominal team, but what happened in the chest was our territory for now. I will come back to that later. As said, good communication and collaboration is crucial. Why is that? Because we have shown, and not only we, but in Leuven we have done a lot of work on explant times that negatively affect abdominal organs, especially liver transplant, but also kidney transplant. So what we have introduced in Leuven over the last 10 years is not so much a sequential explant where the lung is taken out first, followed by the abdominal organs, like in the setting of DBD, but the simultaneous explants, where the lung and abdominal team work simultaneously during the cold phase. And we have seen, and this is published only this year, we have seen here on the graph on the left that the donor hepatectomy time significantly decreased while implementing this simultaneous procurement without any impact on the pulmonary explant time. And I think that is important to consider, and maybe to do that also in other centers. And then I would like to share some videos of how such a procedure. So after 5 minutes of respect and silence in the OR, the abdominal team makes the first incision. They incise the skin, and then we take over as thoracic surgeons. We make further incision high enough. We go until the sternum. We feel there, just above the sternum, that we can place the sternal saw. At that moment, we will introduce the saw, we will cut the sternum, and then ask the anesthesiologist. By that time, the intubation will be performed, and they can start ventilation with the classic ventilatory parameters with an FiO2 of 50%. Here you can see the abdominal team continues in the abdomen, and here we position the sternal saw. This was one of our fellows a few years ago, just to show that this is not the most difficult procedure. You need to have seen it a few times, but in the end, what you have to do is a sternotomy, keep yourself cool, and then open up the pericardium, do a Mercedes incision, and then position. You see, yeah, she was a bit nervous by then, so she replaced, but that's perfectly fine. We open up the sternum, we find the pericardium, and then we cut the pericardium. The goal is, within a few minutes of warm ischemic time, first to vent the lungs, and secondly to flush. The venting is important because you don't want an overflow of the lungs, creating more edema potentially after hyperfusion. So what we do for venting, we cut the left atrium and the inferior caval vein, and then we flush. And this flushing can be done either by opening the right ventricular outflow tract of the heart, or higher up the pulmonary trunk. I myself, when I do the procurement, I prefer to put the cannula in the right ventricular outflow tract because it is just more suitable. Here you can see how this flushing is done. So we open up the pericardium. Sometimes we also place a clamp already at that moment on the thoracic aorta just above the diaphragm to help the abdominal team. But then I advise to be careful not to hit the lung, because sometimes the pulmonary ligament on the left side goes very low. And then we put a Bengo clamp on the basis of the pulmonary trunk. And then most of the time, the fellows, when they start, they want to be sure that they're in the pulmonary trunk, and that's where they cut. What you have to be careful for is the valve, the pulmonary valve, which is there. So don't cut too close to the heart, but just before the bifurcation. And when you introduce the cannula, sometimes there's a very sharp tip that you don't do a dissection of the left pulmonary artery. And here you can see she's looking for the pulmonary trunk. It takes a bit longer than usual because this was her first time, but she's doing great, I must say. And then they will cut. You will see the blood coming out. And then they put in the cannula. And then before they open the cannulation, they will cut the left atrial appendage. What's also important at this stage is that we give some prostaglandins just before the flush. And then what we do, the first liter that we administer of preservation solution is at room temperature. The idea is that you have a good flush of the whole capillary bed without creating any vasoconstriction, which is then followed by 4 liters of cold preservation solution and topical cooling. It's important during the flush that you keep an eye on both lungs, that they decolor very nicely. And then they do an en bloc explant together with the heart. Here you can see how they cut the trachea after double stapling, and then the lungs are taken out. You can see at the same time how the abdominal team is working in the abdomen. It's important to give each other 1 or 2 minutes at this stage when the organs come out, and then we move them to the bench where we will do the splits. In our experience, since we have built up this experience with DCD, it is there at the bench that we make the final decision to accept or to decline the organ. Sometimes it can be very easy when it's, for example, a severe pneumonia or a lot of emphysema. It can be very easy, but sometimes, and that makes it more complex, it can be an intermediate case where you see some emphysema, some bulla, some edema, what to do. And then, of course, the final decision is on the transplant surgeon who will perform the transplant. And then most of the times we do a FaceTime connection to also have a look at the lungs. We remove the heart on the bench. We split the lungs, so the trachea stays with the right lung. And then we do a retrograde flush of 1 liter cold preservation solution per lung through the pulmonary veins. And then we do already some hyalur dissection if the fellow is well routined, just not to lose too much time. And then we pack the lungs separately, either in ice in the camping box or here in the lung guard, which we introduced over 1 year ago. So regarding the outcome, I would like to start with the most controlled setting, which is the DCD-3. In general, you have 2 donor types, 2 strategies. You have the DBD, where you have time. Of course, you have the catecholamine storm of the brain death, but you have time to assess, do blood gas analysis during the procedure, and prepare everything for cannulation, inspect the lungs, and already decide to put the patient to sleep before you do the actual explant. And then, of course, you have the more rushed procedure of the donation after circulatory death. The question has been, is the quality of both equal? And I would like to refer to one of the fathers of thoracic surgery, Joel Cooper, who said that the lung is unique in as much as cellular metabolism can continue in the absence of a circulation, particularly if the alveoli are inflated with oxygen. And indeed, the lung is privileged, because aerobic metabolism can continue because there's oxygen in the lungs, in contrast to, for example, kidney and liver. And that's why probably the hypothermic oxygenated machine perfusion trials of kidney and liver work well, because they provide oxygen to sustain that cellular metabolism. Interestingly, this paper in 2019, published in Journal of Heart and Lung Transplant, looked at the duration of total warm ischemic time in the ISHLT DCD registry, because there's always a lot of debate what to do when you have 2 hours of standoff time, 2 hours of absolute warm ischemic time or functional warm ischemic time. Well, in 99% of cases, reported cases, that warm ischemic time is below 60 minutes. More interesting, however, and that's why I refer to it in the beginning, would be to understand what a functional warm ischemic time is, but not all centers keep track of that data. And I would like to refer to the early work of my mentor, Professor Dirk van Ramdonk, who already in the 90s looked at a rabbit model of increasing periods of warm ischemia with a perfusion. It was an actual perfusion model. After 1 hour, 2 hours, or 4 hours ischemic time, these lungs were not inflated. And what you can see is that 1 hour ischemic time was as well tolerated as the control. But from the moment you went to 2 and 4 hours, there was damage. And also a more recent paper published 2 years ago in a DCD pig model, where there was a control versus 1 hour of warm ischemia versus 2 hours of warm ischemia, followed by 90 minutes of EVLP evaluation, has observed that there was a significant decrease in FiO2-PO2 ratio after 2 hours of warm ischemic time. So in general, the community of thoracic lung transplant surgeons, they agree that 1 hour of warm ischemic time is tolerable. Interestingly, what happens after that warm ischemic time is that the organ does not immediately goes to 4 degrees Celsius. What we have observed last year with all consecutive lung transplants performed in Leuven in 2023, we measured the temperature, and we measured temperature at the moment that we do the pulmoplegia and at the moment that we extract the lung block, and you can see that that period is also important, because although the lungs are inflated at that moment, the temperature is quite high. So this is really warm ischemic time, and it takes a bit of time just until you did the preparation, the retrograde flush, that the lungs go towards 12 or 10 degrees before you then start the actual preservation. In our experience, the time between pulmoplegia and the start of the cold storage was 28 minutes. In my opinion, no one really ever analyzed this explant time of lungs, if it could influence the outcome afterwards, or it could have an influence on PGD, but there is a general consensus that warm ischemic time is tolerable, but the longer it takes, the more risk of PGD you will see. And then we looked in our own center at DCD versus DBD. This was data from 2017, where we did not see any difference between 59 DCD lung transplant performed versus 331 DBD, neither for graft survival or clot-free patient survival. And then, interestingly, there was a systematic review and meta-analysis published in Journal of Heart and Lung in 2015 from Krutzinger, where they observed comparable survival from DCD to DBD. And I share the graphs from this paper here. So both regarding 1 year survival, they did a meta-analysis, there was no difference, as well as for primary graft dysfunction, there was no difference, as well as for the later acute rejection, there was no difference between DCD and DBD. And then I myself did in 2019 a systematic review of all cases reported until then, including the early DCD registry by Marcelo Cipel and the update with 23 centers in 2019 by Van Ramlonk et al., including more than 1,000 DCD procedure. And in none of these studies there was a difference in PGD, in survival or clot-free survival. And here you can see that graph with 547 DCD transplants with a 5-year survival, which did not show a difference between DCD and DBD. And then more recently, that was the last reviewed by Alessandro Paleschi from the Milan group. They also did a systematic review, and they did not find a difference between DCD and DBD regarding short-term outcome, 1 year survival, and PGD. However, they saw perhaps a trend towards more airway complications in DCD. And I think that's an interesting topic that as a community, putting all our data together, could be interested to be looked at in the future. Because of the longer warm ischemic time, there might be the hypothesis that the bronchial healing would be less ideal than in comparison to DBD, but this is not a fact, this is a hypothesis. So that for controlled DCD3. Another controlled group of interest is the DCD5. As said in the beginning, DCD5 accounts for the lung transplants following donation after what we call in Belgium euthanasia. We have some experience with this. We did over 22 cases and published the results in the Journal of Heart and Lung in 2022. When we did a propensity match with DCD, it was a 1-2 match, and with DBD, which was a 1-3 match, and neither for DCD3 or for DBD, we saw a difference in 5-year patient survival or 5-year clot-free survival. And then in the same year, Toronto also shared their experience which accounted for 33 DCD5 lung transplants, which is called the medical assistance in dying, of which 2 were performed at home. And also in their experience, they did not see a difference in survival. It was not a propensity match, but it was compared to the whole group, and there was also no difference in outcome. So regarding this DCD5, of course, this is country and region dependent. In Belgium, this legal and ethical framework is based on the Belgian Act on Euthanasia, which make it possible to ask for euthanasia when you have a medically hopeless condition with unbearable physical or mental suffering with no prospect of improvement. Following approval, a patient, him or herself, may voluntarily express the willingness to donate after that. And that is then reviewed by the ethical committee, safeguarding a strict separation of euthanasia and donation. What is also important to understand for now, it is not allowed that the physician informs the patient that will ask for euthanasia about the potential of donating. So it has to come from the patient him or herself. And then coming to maybe still unexplored potential expansion of the donor pool, which is the uncontrolled DCD2. So I would like to first refer to the experience from Puerta de Hierro in Madrid, Spain, who published their early experience with 29 lung transplants from between 2002 and 2009. They reported acceptable results, however, with higher rates of PGD. If you look into the legal framework of uncontrolled DCD in that setting, which means that after witnessed cardiac arrest, the emergency units go to the patient. They start basic and advanced resuscitation within 15 minutes. Later, it was broadened up to 20 minutes and then transported the patient to the hospital, to the ICU. The patient is certified dead, and then legal permission for organ preservation is requested from the judge on duty. What they do then is that they insert chest tubes on both hemothorax for topical cooling, with then a maximum allowed warm ischemic time of 120 minutes. Then the next of kin is found and asked permission for donation, and then a new authorization for the retrieval of the organs is granted by the legal office, with a maximum preservation time of 240 minutes. And then after classic antegrade lung perfusion, and there has been some debate on the value of this evaluation, because what they did is they took 300 milliliters of donor blood and infused it in the pulmonary artery, and then they tested the blood gas. And then they did the retrograde perfusion. And here you can see indeed that the survival was not ideal, with a 65% survival at 1 year. So they, in their own paper, they finished in the discussion saying that there is a need for ex vivo lung perfusion assessment to clarify between suitable and non-suitable donors. And then also this paper came out also from Spain. They updated their series to 38, of which 8 then at EVLP, and they compared it with brain-dead donors. What they saw was still a high rate of PGD2 and 3, which is 55%. And 6 out of 8 EVLPs also developed PGD2 and 3. If you then look at the survival, there was a significant survival benefit for brain death in comparison to uncontrolled DCD. However, that seems to be only the case for the later follow-up and not so much for the early follow-up. This is something that's difficult to explain, probably because the number is too low. And then a very nice paper came out from Santander, from the group from Minambres, very well known for all the donor management and the protocols for uncontrolled DCD, with an excellent 5-year survival of 87.5% in 8 uncontrolled DCDs performed between 2012 and 2018. 2 of these donors underwent EVLP for evaluation. What was interesting in this protocol was to see that there was a very strict selection with very strict criteria for lung donation after uncontrolled DCD, and also that the body temperature was cooled during the evaluation period to a temperature of 20 degrees, monitored by a transesophageal temperature. And then also Toronto, who have, of course, a lot of experience with EVLP, shared their results in 2020, where they performed 5 uncontrolled DCDs and all underwent EVLP. And very interestingly, they shared their 4 hours of EVLP data, showing in blue the ones that were transplanted. And as you can see, they were also very selective in accepting, with PF ratios going around 500. And these patients did well. None of them developed PGD3, and one patient who was bridged AU died later onwards to multi-organ failure. So I think if we would like as a community to further explore the potential of uncontrolled DCD, I think it is important to understand further how we can protect the lungs during this extended warm ischemic phase. Perhaps we can improve ventilation protocols like published, for example, by the Milan group, who performed recruitment maneuvers and continuous PEEP. Perhaps there could be a role for protective gas anesthesia during that period of warm ischemia. What is the role of topical cooling? Should we still do that? And what is then the ideal temperature, knowing everything about controlled hypothermic storage around 10 degrees, 8 degrees? And then maybe we should add some protective metabolites to the static preservation solution around the lung. So with this all set, how should we assess the donor lung quality of a DCD donor? I think there are 3 options. Either you do it ex situ, with assessing the lung on the bench, like we do in Leuven immediately after explant, or you use the ex vivo lung perfusion. You can also do it in situ, like in a DBD procedure, that is in a thoraco-abdominal NRP. After you wean from ECMO, you can do an in situ blood gas analysis, like we did in Leuven in our 2 cases. What we know about EVLP is that there is, of course, an increase in experience worldwide, especially led by the team of Toronto. My personal opinion, and this is solely a personal opinion, on the role of EVLP in DCD is that in the controlled setting of DCD, based on our gained experience over the last 10 years about assessing a suitable lung for transplantation, I don't think you need systematically EVLP if the agonal plus asystolic phase is short, meaning the classic golden hour below 60 minutes. But if you have an extended, especially functional warm ischemic time going beyond 60 minutes, which accounts only for a very small percentage of the controlled DCD worldwide, then I think it would be wise to use EVLP. In the uncontrolled setting of DCD, I think, yes, we have no experience, but if we would continue that path, I would feel more comfortable to first do an EVLP and assess the lung before implanting it. However, in the Spanish experience, if you adhere to very strict criteria regarding the donor suitability and the warm ischemic phase, you might consider to accept it without EVLP. And then 2 very interesting papers came out last 2 years about the role of DCD and EVLP. And 2 papers came out simultaneously, and they were based on the UNOS data. What they saw is that, and what they did, they compared 4 cohorts: DBD without EVLP, DBD with EVLP, DCD without EVLP, and DCD with EVLP. And these are a large number of patients. And what they did was they did a multifactorial risk analysis. And what they saw, both independently from each other, was that DCD with EVLP led to a worse 1-year survival. So there could be different explanations for that. And I think we need to be very careful with interpreting that data. Nevertheless, it deserves our attention. Because indeed, EVLP on itself may also potentiate additional damage through different mechanisms. That being said, we have to be also careful, and there might be some selection bias in those that were treated with EVLP versus those who were not treated, despite the fact that this was a multivariate analysis. And also perhaps the device that was used, because this is UNOS data, might also have played a role. Nevertheless, I think that with using an EVLP in a DCD setting, there might be a second hit phenomenon. And I would like to explain that with the following case that we transplanted in Leuven, who should deal with the reperfusion edema, Should it be the patient or should it be the EVLP? And I think considering that, it's also important to take the status of the recipient into account. And I refer to this CT scan, where you can see a classic controlled DCD3 with a donor who hung himself. He had a pneumonia, he was ventilated for 2 weeks, and he has on the last CT some edema of the left lower lobe. We go out, we retrieve the lungs, they are on the bench, and we indeed can see that the left lower lobe is a bit edematous. So what we do in this case, we transplant the right lung first, so that the left lung, that inflammatory environment, is only added at the latest to the recipient, and the hyperfusion edema on the left lower lobe is anticipated for the first 24-48 hours. However, this patient can cope it. He was still relatively young, and he can cope such a hyperfusion edema. It might be true that if you put these lungs on EVLP, they become more wet. They have the PGD already on the EVLP, and if you then transplant them, then it can worsen your transplant on its own, requiring prolonged ECMO or a difficult implant because you have this edematous lung. In the end, this patient was intubated for 48 hours, then extubated, and he did well because he could cope that first PGD phenomenon. This is something to be discussed and will be center specific. So what are the indications for EVLP? I think indeed reassessment of questionable donor lungs with a maximum EVLP time probably around 4 hours. Not anymore for prolonged preservation of healthy donor lungs for logistic reasons, which was one of the indications previously. But I think now with the whole story of controlled hypothermic storage, that is probably the device to do prolonged preservations. And then the real value is in the future allograft treatment and modulation. The money is in the ATM, where with a good platform of normothermic ex vivo lung perfusion, we can actually start treating the lung like some groups have already done in the past. And then there might be a value to a remote ex vivo lung perfusion at the centralized evaluation facility where it has been observed that more lungs are finally transplanted. So that regarding the classic DCD setting as we know it. I would like now to go to a more recent innovation, which is introduction of the abdominal NRP in the setting with rapid recovery of lungs and heart. So what is abdominal normothermic regional perfusion? Well, it was installed because, as told in the beginning, a DCD liver and a DCD kidney do not have the privilege to have oxygen on board, and they suffer more from the DCD setting than, for example, the lung, resulting in more primary non-function and biliary complications. So in these settings, you introduce a normothermic regional perfusion at the beginning after cardiac arrest, and you can do a rapid recovery of the lung. What is important in that setting is that you take good care of the hemostasis with ligating the azygos vein and making sure that there is not too much bleeding in the chest, so that the normothermic regional perfusion in the abdomen can run. But you procure the lungs immediately. Also said that if you need more time for optimal hemostasis, you should consider probably that the warm ischemic time also prolongs. And so this was also introduced again by the same team of Minambres, who looked between 2014 and 2018 to 21 lung transplants from 19 controlled DCD, and they did not observe a difference, although there was a longer warm ischemic time of taking out the lungs in comparison to DBD. Also in this setting from Puerta de Hierro in Madrid between 2013 and 2019, they did a retrospective analysis of 28 consecutive lung transplant from controlled DCD. 14 were rapid recovery, classic DCD, and 14 were rapid recovery with abdominal NRP. And also in their experience, there was no difference between the two settings. And then you have the updated data from Minambres between 2014 and 2021. 60 lung transplants were performed with EVLP used in 2. What they did observe, although there was no difference in survival, there was more PGD3 at T72 in the abdominal NRP group versus DBD. So this can maybe again be attributed to the warm ischemia, perhaps, but there was no impact on overall survival. And I would also like to refer to the great experience from the French group led by Edouard Sage, who systematically put all their DCD on EVLP. So they did 76 DCD EVLPs, including in situ abdominal normothermic regional perfusion. Their PGD2-3 at T72 was 29%, and their 1-3-year survival was excellent, with a 3-year survival of 85%. Interestingly, in their protocol, that is that the NRP is started before the patient is transferred to the OR, which also increases the length of warm ischemic time to the lung. That's it for the lung. I think as a thoracic community, it is really important to understand that DCD heart transplant makes a difference. And we have to support it as a thoracic community and not fight against it, because these hearts help people. And this paper was published in Journal of Heart and Lung Transplants only last month, showing indeed that in the UNOS analysis, donation after circulatory death in hearts significantly reduces the waitlist time while not changing post-heart transplant outcome. And this is already quite a very high number of DCD hearts performed, 425 compared to 850 DBD, with an excellent 2-year and not different patient survival. What is important to understand, if we have a donor where we have a DCD heart, which is directly perfused and procured, called DPP, there are two options for heart preservation. Either you do an ex situ normothermic machine perfusion so that you can also evaluate and preserve the heart, or you do an ex situ hypothermic machine perfusion, which is a hope, where you can hopefully in the future prolong preservation of the heart. I refer to the case of the transatlantic machine preservation that was transplanted. The heart was transplanted in Paris. It flew transatlantic and it was preserved for 12 hours, but that was from a DBD. What is important in this setting is that everything should be done to limit the heart warm ischemia time, so the cardioplegia gets priority. And then we wait until the heart is explanted to actually perfuse the lungs. And for this perfusion, we need a different system, because a simple catheter does not work, because the pulmonary trunk is cut. So what we use, and this was published also by the Vienna group, what we use is a double balloon catheter that is inserted in both pulmonary arteries. What we do in Leuven in our protocol for DCD heart, when it is simultaneous lung procurement, is that we start ventilation after the cardioplegia. So we don't wait until the explant of the heart. And then both the Vienna group and the group in Duke has looked at the impact of prioritizing heart procurement in DCD. So Vienna looked at 7 heart-lung procurements versus 49 DCD lungs. There was no impact on PGD or 1-year graft survival, although the warm ischemic time was longer when the heart was procured. And also Duke showed this year, a lot of very interesting papers came out this year in this topic, I must say, showed that in their direct procurement of lung transplants, which is 40 compared to a normothermic regional perfusion of the lung versus DCD, there was no impact on survival. So that said, we make a link to the final part of this presentation, which is the thoracoabdominal NRP. So regarding the thoracoabdominal NRP, what's the idea? The idea is that apart from just perfusing the abdominal organs, you also restart the heart function in the donor itself by using an ECMO system and clamping all the supraortic vessels just to make sure that you have no flow to the brain anymore. It is interesting because there are, of course, several ethical concerns to thoracoabdominal NRP, because that resumption of cardiac activity within the donor, of course, reverses the permanence of circulatory arrest used to declare the donor dead. And we must make sure that there is no recirculation of the brain. On the other hand, it is said that normothermic regional perfusion is permissible because it does not lead to a spontaneous resumption of circulation, and it enables more patients and families to fulfill their wish of organ donation. So you do the greatest good because you help the most patients. So if NRP is permissible and provides a better outcome, it would be, in fact, ethically obligatory to use this procedure. But you see, there are many pros and cons in this debate. And I think as a community, it is important for us to understand what the impact is of that restart circulation on the brain blood flow. And there was one paper coming out last year where they looked at intraoperative transcranial Doppler in 2 DCD TA NRP cases. And here, looking at the basilar artery, they did see no they saw a complete flat line after the introduction, the restart of circulation, but perhaps more data is needed to convince the community. What is then the potential advantage of the TA-NRP over the direct procurement, especially for the heart, is that you can do a thorough cardiac assessments with even a transesophageal ultrasound of the heart before you actually procure and decide if you will accept this heart or not. Secondly, NRP substantially reduces that warm ischemic time and may perhaps better reverse the injury than with ex vivo perfusion. And then it's important to understand, of course, what has the best outcome, DPP versus TA-NRP, because this will impact probably the setting of DCD donation in the future. And there is one paper is currently in Journal of Heart and Lung, pre-proof, so accepted, but proofs are not corrected yet, where they compared based on the OPTN data, where they compared 102 DCD heart direct procurement versus TA-NRP, and there was no difference in outcome. So after 1 year, there was a probability for both of more than 90% survival in the matched cohort analysis. This should be confirmed in the future. So regarding the thoracoabdominal NRP, what is the technique? You start classic DCD after you put in the cannulas in the groin. You do a supraortic clamping. You start the ECMO. The heart restarts. You can wean from ECMO. You can also assess the lungs at that moment. And then you are in a DBD setting where you can simultaneously flush heart and lung and reduce the warm ischemic time. However, it is logistically demanding, especially if you have to go to a donor center. This is the setting of one of our TA-NRP procedures in Leuven. You see, you need a lot of logistic, a lot of people. And this is the setting of such a TA-NRP, where all the supraortic vessels were not only clamped, but also drained in that setting. During this procedure, I was also able, after the ECMO was weaned, to take an in situ blood gas analysis of the lower pulmonary veins to assess the lungs. And here you see a short video of how the supraortic vessels are drained after the heart restarted. This was published in Journal of Heart and Lung Transplant 2 years ago. So what is the impact on the lung of a TA-NRP? There's not a lot of data yet. What we should really carefully assess if that in this setting, because of all the logistics involved, the lack of resources perhaps, there would be a decreased utilization of these lungs, which would otherwise work perfectly. We should avoid an increased post-capillary resistance and an overload of lung leading to PGD. The good thing is that we can assess the lungs in situ and that we might not need EVLP afterwards. There is this paper of 22 TA-NRPs that I would like to refer to, because in this setting of 22 DCD TA-NRPs, 19 hearts were utilized, 86%, and 6 lungs, which is 27%, which seems quite low to me in comparison to that heart, with a 14-month survival of these 6 lung transplants of 100%. So regarding that dilation of the left atrium and that increased post-capillary pressure, I would like to draw your attention to that, because so what we do is, so we restart ventilation after that declaration, and when the ECMO is started, you will see a bronchial circulation via the aorta. And there's no PA circulation until the RV output restarts of the heart. And so what you get with this bronchial circulation running through the lungs, it dilates your left atrium, which increases the afterload, which might increase the risk for cardiogenic edema of the lungs. So what we do, we vent that left atrium. We vent that left atrium together with the ECMO. The Colorado experience also reported on that venting. What they do is they put a cannula in the pulmonary artery to vent the pulmonary artery that can then be later used as a cannula for flushing. And here you see the UNOS data published last year on the impact of thoracoabdominal NRP on early outcomes for lung transplantation. Again, I must say that the utilization rate in these normothermic regional perfusion DCDs is quite low. It is 14.9%. However, there's no difference, significant difference in outcome when you compare them with a direct procurement. So this is very convincing data, I must say. Here's the two experiences from Leuven, published in Journal of Heart and Lung Transplant, with one patient experienced PGD grade 3 at T48, the other patient not. So in conclusion, Clemens, I would like to state that for DCD 3 and 5, there's equal quality as for DBD. For uncontrolled DCD2, I think this is a further potential for expanding the donor pool, but we must adhere to strict criteria and use EVLP. For abdominal normothermic regional perfusion, which might potentially become the future of DCD donation, with direct procurement of the lung, there is no impact. However, the warm ischemic time is a bit longer. For those where the DCD heart is also simultaneously directly procured, there's also a longer warm ischemic time, but there is no impact on outcome. And then for the DCD heart TANRP, my advice is to vent the lungs to decrease that post-capillary pressure. And we will need to learn in the future if the impact of DBD direct procurement versus NRP, if there is a difference or not, because this will probably lead to the final in the future setting of DCD if we go for abdominal NRP or for thoracoabdominal NRP. What we have as a community to safeguard is the utilization of donor lungs. So the future of DCD lung transplant will depend first on the outcome of all these different settings, but also on the center and the region-specific costs and logistics that come with these settings. What we have to visualize for the lungs is that despite the injury that will occur, we try to avoid this as much as possible. We try to prevent the injury as much as possible, but we try to find the balance between, on the one hand, the metabolic needs, and on the other hand, the oxygen consumption, as long as the aerobic metabolism is continuing. So what we did in Leuven since January 2023, we introduced for the controlled hypothermic storage, not only for prolonged preservation to bridge the night, where we use the CHS for every procurement after 6 o'clock in the evening, but also for logistical limitations. And for example, when you have a lack of resources, consider to use the controlled hypothermic storage to still use the DCD lungs for transplant. And we also use it for extended criteria donors. I can share that in September last year, we used a 94-year-old DCD donor with success to an older COPD patient. And we used also in this setting the controlled hypothermic storage, or in very high-risk recipients where you need additional time. And with this controlled hypothermic storage, we can extend safely the preservation of lungs up to 15 hours, following the initial experience of Toronto. Last week, we published 13 cases from Leuven, Prague, and Boston, with the longest ischemic time up to 22 hours without any PGD3 at 72 hours. So I think, being the sole surgeon in the chest for so many years in the DCD setting, I think now as a thoracic surgeon, we need to make space for the cardiac team in the good harmony for the benefit of transplantation of all organs. We are not anymore master and commander in the chest, but that's no problem because we can help more patients. And at the end of this presentation, I would like to make some advertisement for the upcoming ESTS meeting in Barcelona, end of May this year, where we have dedicated a lot of time to the transplant community. So on Sunday during the biology club, we will talk with invited lectures on the role of complement in lung transplant, as well as the genetic modulation in lung transplantation. On Monday, Dr. Shafke Shafshi will give the invited lecture on his journey through thoracic surgery and lung transplantation. We will have invited lectures on the role of NRP in lung transplantation, followed by the abstracts of lung transplantation. And then on Tuesday morning, there's a Sunrise Symposium. It's a combined ESOT-ECTA and ESTS symposium, where we will talk about controlled hypothermic storage in lung transplantation. I would like to thank the whole Leuven lung transplant team and the audience for their attention. Thank you very much, Clemens.
Thank you very much, Lawrence, for this really excellent and encompassing overview. The DCD fraction on the total donation rate really hugely varies depending on legal situation and actually also approach towards ends of life issue in different countries. Belgium is one of the countries with the highest share of DCD donors. So how do you explain, for example, in Spain, there's probably more utilization of normothermic regional perfusion procedures compared to Belgium when looking at the published data. How do you explain this difference? And until further data directly comparing the different approaches become available, do you have sort of a suggestion for an algorithm, what to use in what situation?
Thank you, Clemens. Indeed, it is very region specific. Only in Europe, there are so many differences, also ethically. What I can say for Spain is that they have a long-lasting experience with uncontrolled DCD, with very strict development of protocols. They have done a lot of thinking about these settings. We've also done the logic introduction of NRP. I think it makes perfect sense. In Belgium, we were a bit later with the introduction of NRP. We have a very, very limited experience with uncontrolled DCD because of mainly logistical limitations. And then currently with the thoraco-abdominal NRP, we have stopped the program in Leuven after our initial experience because of more ethical concerns and the question of ethical committee, for example, in Leuven, to make sure that there is no recirculation of the brain. And so these ethical concerns are really what dictates the evolution in the use of NRP. I think just in Spain that they are a bit further in studying and discussing all these topics. Regarding some kind of template used which donor for which for which setting for which donor in DCD, what I think is that the answer will be given probably by the heart team. If you can show that the direct procurement of the heart with normothermic or hypothermic preservation results in the same outcome as a normothermic regional perfusion in the chest, then probably that normothermic regional perfusion will be considered more complex and logistically challenging in most of the cases, unless you have a very strict and motivated donor center. But otherwise, probably we will use the machines and we will use the abdominal NRP in the abdomen because it might cost less than, for example, using the devices for lung, for liver and kidney. So in the end, I think that we can develop a template of what would be best for which organ, but in the end, it will probably also come down to a cost and logistical issue that will be really region dependent. What I foresee in the future is a bit what we have seen with the EVLP as well, where the devices are reimbursed in North America, but not in Europe in most centers, where you can see that there is an increase of use of EVLP in the US, but not so much in Europe, where it's more difficult to compensate for that. And that will probably be the same for NRP. NRP will be probably cheaper than the devices. So it will depend if most regions accept reimbursement for machine perfusion of the heart, then we'll probably go that direction. Otherwise, it will be more normothermic regional perfusion. But then you have to consider that donor centers need prolonged time of their OR, more logistics to the procurement team. So that will probably dictate the future. Regarding the lung, Clemens, I think if abdominal NRP is performed and you can do a direct procurement with safeguarding the bleeding, I don't see that there will be a major impact on the lung, and we don't need EVLP to assess these lungs. You will just gain a few minutes of warm ischemic time. If there is TA-NRP involved, I'm a bit worried for the lung, and we have to await future data and studies, because also the introduction of the ECMO, the post-capillary overload, that might cause inflammation, and we have to be careful that a perfectly suitable lung otherwise might turn into an edematous lung. That's my opinion.
There's also a question from Anna Minassian regarding the maximal acceptable duration for TR-NRP before stopping and doing the evaluation in combined heart and lung donation. Is there a maximum time? In Spain, she states it's 30 minutes.
Before you consider to stop and evaluate, there's in our experience there was not a maximum time. I know in the first case where we did the TNRP, we only stopped after 103 minutes. We already did an real stop weaning from ECMO. We already did an evaluation sooner by just turning off the ECMO, but there's not really a maximum time. I think you can prolong ECMO. What we did in one of these cases was that in the OR next to the procurement, the patient was put asleep, completely prepared for heart transplant, and then only when the recipient was on cardiopulmonary bypass, the sick heart was taken out, then only the heart was procured, and without any cooling down of the heart, just put it in a bit of ice, it was transplanted into the recipient. So I don't see why there would be absolute a maximum time. I hope, Anna, this answered your question.
Okay, thanks a lot, Lawrence. We've already come to the end of today's webinars for time constraints. It was really an excellent overview you gave. I think it's really a highly interesting topic, which will see a lot of developments in the close future with the TR-NRP. I'm sure about that. And I'd also like to invite you to join our next ESTS webinar, which will take place on April 15th. And Marc de Bureau will cover the topic of surgery for malignant pleural mesothelioma. It's an interesting time for mesothelioma surgery. And then, of course, also, like Lawrence mentioned, we're looking forward to the ESTS meeting with all its different aspects and a close focus on transplantation as well this time. So
thank you very much, Clemens,
for joining in today, and see you soon.
Have a good evening, everyone. Bye-bye.